Hello and welcome to Zoology 142 Online. This is our second lecture on the reproductive system. Today we're going to look at female reproductive anatomy and the physiology behind the female reproductive cycle. So in today's lecture we're going to identify the female reproductive anatomy. We're also going to discuss the hormones which control the female reproductive cycle. We're going to describe the physiology of both the uterine and ovarian cycles and briefly describe the female sexual response. We're also going to discuss the efficacy of different types of birth control and finally talk about STDs, that is sexually transmitted diseases. And finally, towards the end of the lecture, we're going to talk about the changes associated with menopause. So if you remember last week, we talked about the few different functions of the male reproductive system. We said that the male reproductive system basically just has to produce gametes, it has to produce testosterone, and it also has to get the gametes where they need to be. So it needs to have a penis for intermission. As it turns out, the female reproductive system is much more complex and has many more different jobs. And these include the production of gametes, such as oocytes or ova. It also has to produce estrogen and progesterone. It also has to serve as a site for intromission, that is to receive the penis. It has to secrete mucus and other secretions. Also, the uterus has to gestate and nurture the fetus, and this is something that the male reproductive tract doesn't have to do. After fertilization occurs, male reproductive tract doesn't have to be a part of it, but the female has to gestate this fetus for the next 9 months. And finally, we also have to deliver this fetus during parturition, and after that, the female is actually going to have to nurture the offspring through breastfeeding. So again, females have a much larger job than males when it comes to reproduction. In comparison to males, females also have more parts and more complicated parts, and these include the ovaries, which is the site of ova production, the fallopian tubes, which transmit the oocytes or ova into the uterus. The uterus, of course, is the place where we house the developing embryo and later on fetus, and all of the internal supporting structures and ligaments that support the uterus, the vagina, and also the fallopian tubes. The vagina itself is going to be a site for intromission, or sexual intercourse, and then we're going to talk about the external genitalia, which are collectively called the vulva. So the ovaries are the female gonads. This is where we produce our haploid gametes, and these gametes are called oocytes, and later on they will actually be called ova once fertilization occurs. The ovaries are homologous to the testes, that is, they're derived from the same tissues, and they are connected to the uterus via the fallopian tubes. The ovaries themselves are anchored to the wall of the uterus by an ovarian ligament, and also to the wall of the body cavity by a suspensory ligament. Now we're going to take a look at the histology, or at least the artist's rendition of the histology of an ovary. Just like any other organ, it has a pretty good blood supply through the ovarian artery, and that blood supply is drained through the ovarian vein. And on the outside of the ovary, we find something called the germinal epithelium. And this was a little bit of a misnomer. Originally, we thought this is where the actual oocytes were created, but we now know that's not true, but we still stick with the name calling it the germinal epithelium. Just underneath that, we will find something called the ovarian cortex. This is the outer part of the ovary, and deep to that, of course, we'll find a medulla. Now, within the ovary, we're going to find thousands and thousands of follicles at different stages of development. A follicle, if you remember, is a sac of epithelial tissue that secretes something. In this case, we're talking about the sac of epithelial cells or granulosa cells that surround the oocyte or egg. And so we collectively call both the egg and the cells surrounding it the ovarian follicle. We're going to talk more about the process of oogenesis later on, but you should know that the follicles come at different stages of development. Most of the follicles within the female ovary are going to be called primordial follicles, and these are the least mature. And under the direction of FSH, some of these primordial follicles will develop into primary follicles. Primary follicles have a nice granulosa layer surrounding the oocyte, and the primary follicle will grow into a secondary follicle based on the stimulation of FSH, or follicle stimulating hormone. As that follicle grows under the direction of FSH, it will thicken its epithelial layer or granulosa layer, and this layer will then begin to secrete estrogen and later on progesterone. And these are going to have effects on other areas of the body, for example the breasts, the hips, and also the uterus. In most females, one of the secondary follicles will go through continued development each month to become an antral follicle, otherwise called a Graafian follicle. An antral follicle has this large fluid-filled cavity on the inside that is in fact much larger than the egg or oocyte that it's surrounding. Under the influence of LH or luteinizing hormone, one of these follicles will rupture each month, and this process is called ovulation. And basically during ovulation, the follicle ruptures, forcing the oocyte out into the abdominal cavity where hopefully it's going to enter the fallopian tube. Now what's left over is a ring of follicular cells. So even though there's no longer an egg or oocyte within that follicle, it's still going to be very important, because now the follicle is going to be called a corpus luteum, and instead of secreting primarily estrogen, it's going to go on to secrete primarily progesterone. And progesterone has an effect on the uterus. Specifically, it tells the uterus to maintain its uterine lining in hopes that we can have a zygote or fertilized egg that is going to soon implant on that endometrium and be gestated during the next 9 months of pregnancy. Now, if fertilization does not occur, that corpus luteum will eventually break down or degrade into something called the corpus albicans, or white body. The corpus albicans no longer secretes progesterone, and without progesterone, the uterine lining is going to start breaking down through the process of menstruation. Now, if you didn't get this whole process right now, don't worry about it. We're going to go through this at least once or twice more in this lecture, but it's important to realize that what's going on in the ovary is dictated by the hormones FSH and LH, and of course that's dictated by our hypothalamus and GnRH. And that the ovary, in addition to producing our gametes, is also going to produce estrogen and progesterone. And both estrogen and progesterone are important not just for ovarian development, but also for setting the timing of pregnancy and maintaining the uterine lining. Now we're going to talk about the process of oogenesis, and this is a process where we basically take an oogonium, which is diploid, and have it go through mitosis and meiosis to come up with haploid oocytes. And an oocyte is basically just an immature egg. Now the big differences between oogenesis and spermatogenesis is that spermatogenesis is going on all the time. We are literally producing millions and millions of sperm each day. In contrast, females are actually born with all the eggs that they're ever going to have. They actually don't make more throughout their life. And so once they get to puberty, they're going to have around 250,000 immature oocytes or eggs, and only a fraction of these will actually go through ovulation. Now, another big difference is that meiosis in females actually begins during the fetal period. But during the fetal period, meiosis 1 will pause during prophase 1. And it's not until puberty occurs and we have our first ovulation that we will actually complete the first stages of meiosis 1 and enter meiosis 2. Now, meiosis 2 is not completed until after fertilization occurs. That is, the egg is already ovulated, it's entered the fallopian tube, and once it's fertilized by the sperm, the second set of divisions will occur in meiosis 2. The other difference between males and females is that in males, for every spermatogonium, we got a total of 4 spermatozoa, whereas in females, for every oogonium, we tend to only get 1 functional oocyte or ova. And that's because during oogenesis, the cells that divide through meiosis divide unevenly. So take a look at the picture. You can see that our primary oocyte divides into a large secondary oocyte and a much smaller polar body. Now, this first polar body contains half the set of chromosomes but little else. And it's probably not able to be fertilized. And it may divide once more, it may not. But the big point is that the secondary oocyte will then combine with the sperm through fertilization. It will divide again, forming the second polar body. So in essence, we only get 1 fertilizable cell for each oogonium. There are exceptions, but in general, you should remember that we get 4 sperm for every spermatogonium, but typically only 1 functional oocyte for each oogonium. Now, once eggs are ovulated from the ovary, they will then hopefully enter the fallopian tube. You can see on the screen that the fallopian tube has this basically large hand-like receptacle that is called the infundibulum. And the infundibulum is basically the door to the fallopian tube, but it's not completely connected to the ovary. So a lot of times it's possible that an oocyte can get ovulated but may end up in the abdominal pelvic cavity and not actually enter the fallopian tube at all. Now, the fallopian tube is important because it helps to transport the oocytes, or ova, from the ovary to the uterus. It is also the site of fertilization. So sperm are typically ejaculated in the vagina, they swim up the uterus and up either one of the fallopian tubes, and if they make it to the right tube, fertilization will happen at the anterior 1/3 of the fallopian tube. Now, to help facilitate the movement of the fertilized egg, the fallopian tube is lined with both ciliated and non-ciliated epithelium. Now, while we're on the topic of the fallopian tubes, we should talk about a very common birth control method, and that's called tubal ligation. And during tubal ligation, we basically sever the fallopian tubes. And what this does is it prevents sperm from getting up to where the eggs are, and it also prevents a fertilized ova or zygote from moving from the fallopian tubes into the uterus. And so tubal ligation is over 99% effective when done properly. Unfortunately, it's also one of those types of birth control that you need to be really sure that you don't want to have kids, because it does have a fairly low success rate if you want to reverse it. Typically, it's less than 50%. But a lot of couples do look on tubal ligation as a very reliable form of birth control once they're sure that they don't want to have any more children. And of course, the fallopian tubes lead to the uterus. The uterus is probably the most, or at least second most, important female reproductive organ, because it is the site for implantation of the fertilized egg or zygote. It's also going to help to nurture the fetus during gestation, so we're going to have a placenta that connects the mother to the developing embryo and later on fetus. And it also has to help assist with the delivery of the fetus. And so one of the things that the uterus contains is a lot of smooth muscle to help expel that fetus through the vagina when it's time to be born. And of course, when we're not pregnant, the uterus is also the site of menstruation, that is, shedding of the inner endometrial lining. Now, the uterus is actually quite small in women that haven't had children. It's about the size of a small pear, but during pregnancy, it can get to be several pounds and quite large. During pregnancy, the uterus can reach all the way almost up to the sternum. And so it's an organ that's capable of growing in size and stretching in size a great amount. And so it has to be held in place by some pretty heavy-duty ligaments, and we're going to talk about these in just a minute. Okay, now we're going to go through the particulars of uterine anatomy, and the first one of these anatomical terms is fundus, and the fundus is the large rounded part of the uterus superior to the entrance of the fallopian tubes. Now, you probably remember that we had a fundus in the stomach, and it was also a nice rounded area. So remember that the fundus tends to be the rounded area of any organ. And just like the stomach, the uterus also has a body, which is the main part of the uterus. And within the body of the uterus, of course, we have a uterine cavity. This is going to be the area where the embryo and later on fetus is basically housed during gestation. Now, inferiorly, the basically cavity of the uterus will narrow into something called the cervical canal. And of course, the cervical canal is basically a passageway through the cervix. Now, you've probably heard of the term cervix before, as in cervical cancer. Now, the cervix is important not just because it's a site where cancer occurs, but also because it is the juncture between the uterus and also the vagina. And it's important because it's an area that we can sometimes isolate. That is, we can sometimes close off the cervix and prevent things from getting from the vagina into the uterus. And this happens because cervical mucus tends to become very sticky and coagulate prior to ovulation, but closer to the time of ovulation, that cervical mucus breaks down, which allows a passageway for spermatozoa to enter the uterus from the vagina. But if we're not having fertilization occur, basically that cervical mucus will go back and become very, very gooey again, thereby isolating the uterus from the rest of the female reproductive tract. Now think about why this might be beneficial. Remember that the uterus contains all types of secretions like glycogen. It's a very warm area, lots of nutrients present. It would be an ideal area for bacterial infection to occur. And we don't want that to happen, and so one way to prevent this is basically to form a cervical mucus plug in the cervix that prevents things from getting from the vagina into the uterus. Now, we can't have that happen during the time of ovulation because we need our sperm to get up through the cervix into the uterus and into the fallopian tubes. And so around the time of ovulation, that cervical mucus will begin to break down, and that will allow patency or openness between the uterus and the vagina, and that'll allow the sperm to get up into the uterus and eventually make it up into the uterine tubes. Now, as I said before, the uterus can get to be a fairly large structure, particularly during pregnancy, and so we have to have a lot of supporting tissues to hold it in place. And one of these is called the round ligament. The round ligament basically connects from the superior aspect of the uterus, and it runs through the inguinal canals to connect to the subcutaneous tissue within the labia majora, which is part of the female external genitalia. There's also a mesentery-like sheet of connective tissue called the broad ligament, which helps to further anchor the uterus to the inside of the abdominal cavity. Now, lest you think these connective tissues aren't very important, I would like you to stop the lecture now and look up the term uterine prolapse, and you'll understand just why the round ligament, the broad ligament, and the other ligaments of the uterus are so important. Okay, so now we're going to talk about the histology of the different layers that make up the uterus. On the outside of the uterus, we'll find something called perimetrium. Remember that peri means around or outside, and metrium means, in this case, uterus. And so the perimetrium is the outermost layer of the uterus, and it's made up of a serous membrane, essentially connective tissue and some epithelial tissue. Now, deep to the perimetrium, we're going to find a middle layer called the myometrium. Remember that myo means muscle, and so the myometrium is going to be composed of a very thick layer of smooth muscle. And this smooth muscle is important because it's going to help us to expel the fetus at the end of pregnancy. And so those contractions that a new mother feels during birth are due to muscular contraction of the myometrium. And finally, the internal layer is called the endometrium. And the endometrium is basically composed of simple columnar epithelium underlain by a very thick layer of connective tissue. And the endometrium is basically divided into two layers: a superficial stratum functionalis and a deeper stratum basalis. Now remember that the uterus is a site for implantation of the zygote and later embryo, and so we're going to form a connection between the zygote and the uterus through the stratum functionalis. The stratum functionalis has lots of glands in there that will secrete things like glycogen, and this glycogen is important for helping to maintain the uterine and vaginal pH, and it's also important for providing a little bit of nutrition to that developing zygote until a placenta is formed. Now, we call it the stratum functionalis because it is shed at different periods during the reproductive cycle. So during menstruation, the stratum functionalis is completely shed from the female reproductive tract. And it's the job of the stratum basalis to basically generate a new stratum functionalis every month. And so remember, stratum basalis is always there, and stratum functionalis is created again each month during the reproductive cycle. While we're on the subject of the uterus, we should talk about a very common surgical procedure which involves the uterus called the hysterectomy. Now, a hysterectomy is surgical removal of either the entire uterus or maybe just part of the uterus. And either one of these procedures will render a female incapable of having children. So we can have a partial hysterectomy, in which case we just remove the fundus and lower part of the uterus. And we can have a total hysterectomy where we basically remove all the way down to the cervix, and then something called a radical hysterectomy, which involves not only the entire uterus, it involves the fallopian tubes, the ovaries, and even the superior part of the vagina. And so basically hysterectomies are done for a variety of reasons. We do them to reduce endometriosis, which is an inflammation of the endometrium. We do them to reduce pain during sexual intercourse. We do them to reduce the effects of fibroids that some women have. Now, interestingly enough, the United States does over 600,000 hysterectomies a year, and over 90% of these are done for non-life-threatening conditions. That is, we're not doing them because of cancer or any other reason, but because we're hoping to improve people's sexual life or just reduce the amount of pain they have associated with the uterus. But it is being looked at now as maybe a surgery that's done a little too often. Oftentimes when we do a radical hysterectomy, we also, of course, remove the ovaries, and the name for this is oophorectomy, surgical removal of the ovaries. Okay, now on to the vagina. The vagina is connected to the uterus via the cervix, and the vagina is the site of intromission. That is, the man is going to put the penis up inside the vagina, ejaculate there, and eventually the semen and sperm is going to make its way from the vagina through the cervix and eventually up to the entrance of the fallopian tubes. Vagina also constitutes the lower part of the birth canal, so it has to be fairly elastic. Imagine the size of a baby's head passing through what was normally a fairly narrow canal. And so there are three layers to the vagina. There's an outer layer of connective tissue called the adventitia. Interior of that, we have a very thin layer of smooth muscle called the muscularis, and then inside of that we have a mucosal layer. Now the mucosal layer surrounds the lumen of the vagina. But unlike the mucosal layer we had inside the GI tract, we don't actually produce any mucus here. As it turns out, the mucus that helps to lubricate the vagina during sexual intercourse is actually derived from the cervix. And so that's one very important function of the cervix that we didn't talk about previously. Now the interesting thing about the vagina is that the mucosal layer contains dendritic cells, otherwise known as antigen-presenting cells. It was the job of these antigen-presenting cells to basically go out and grab antigens and present them to our adaptive immune response, that is, our T cells and our B cells. But as it turns out, these APCs can actually be a backdoor for viruses like the HIV virus to infect the female reproductive tract. And so we're trying to figure out a way to block HIV transmission through these APCs, and if we can do that, we can reduce the chances that females will contract HIV through unprotected sexual intercourse. Now the other thing that I think I mentioned previously is that the uterus and the vagina are secreting some glycogen. Now glycogen is there as a nutrient source for the developing zygote until it has a chance to implant. But another big important reason the glycogen is there is that it is broken down by bacteria. And when bacteria break down the glycogen, they tend to produce a very acidic environment. And this is important because we think the acid is basically there as a natural antibiotic to basically retard any bacterial growth that could occur in the uterus and in the vagina. Okay, now we're going to move on to the female external genitalia. Collectively, we call this the vulva. The most superior part of the vulva is called the mons pubis, and mons here means mountain, and so it's basically a little bitty mountain of fatty tissue that is on the superior part of the vulva. And normally the mons pubis is covered with pubic hair after puberty. Inferior to the mons pubis is the clitoris. The clitoris is basically a little bit of erectile tissue that contains lots and lots and lots and lots of nerve endings. And it's homologous to the glans penis of males. And so basically the clitoris is stimulated during sexual intercourse, which results in arousal and eventually orgasm. And so it's a very sensitive area of the body, very important for sexual arousal. Now below the clitoris is the external urethral opening. Now remember that females tend to have a very short urethra, and it tends to be fairly close to their anus, and so unlike males, they tend to have a greater incidence of urinary tract infections because bacteria can easily get from the anus into the urethral opening. Now inferior to the urethral opening we have the vaginal opening, and of course this is where the penis would enter the vagina during coitus or sexual intercourse. Now in virgins, that is people that have not had sex before, the vaginal orifice can be partially occluded by a hymen, which is basically a tissue membrane that is eventually perforated during intercourse or aerobic activities, exercise, and so on. Now external to the vaginal opening are two sets of lips, which are collectively called the labia. The internal labia is called the labia minora, and these are the minor lips. They are very thin, and they're not covered with any hair. External to the labia minora are the labia majora, and the labia majora are large, they are underlain with fatty tissue, and they tend to be covered with pubic hair. The labia majora are basically homologous to the male scrotum, that is, they're derived embryologically from the same types of tissue. Now the next two structures are not technically part of the vulva, but we're going to talk about them anyway because they're very close to the vulva. And the first of these is the perineum. The perineum is basically the diamond-shaped patch of skin between the anus and the vagina. And of course, last but not least, we have the anus. Okay, and before we move on from female external genitalia, we need to talk about one more thing, and that's called the bulb of the vestibule. The bulb of the vestibule is basically a mass of erectile tissue located deep to the labia. And we think that they're important because during sexual arousal, the bulb of the vestibule will become engorged, and it will basically help to grip the penis during sexual intercourse. The other reason we think that it's important because it actually helps to shut the external urethral orifice during intercourse and arousal, which can help to prevent semen or fecal bacteria from moving into the urethral orifice during intercourse. And the bulb of the vestibule is actually homologous to the corpus spongiosum in men. Remember that the corpus spongiosum was basically the erectile tissue that surrounded the urethra and helped to keep it open during sexual intercourse and eventually ejaculation. Okay, next up we're going to talk about the mammary glands. Now the mammary glands really aren't technically part of the reproductive system. They're actually part of the integumentary system. That includes the skin. Now the reason we say they're part of the integumentary system is because they're actually basically modified sweat glands. And that would make milk modified sweat. So think about that next time you're eating dairy. Now, of course, the function of the mammary glands is to basically provide nutrition to a newborn baby. And we're going to talk about some of the internal anatomy of the mammary glands in the next slide. The one thing I should talk about in this slide is something called the Cooper's ligament. The Cooper's ligament is basically an internal connective tissue scaffolding which helps to support some of the weight of the breast by anchoring it to the underlying pectoralis muscle. Now internally, the breast is divided into lobes, and each of these lobes is subdivided by connective tissue into lobules. The lobules contain alveolar cells. These are the cells that are actually responsible for secreting the milk. Now, the milk that's secreted is basically stored in the lactiferous sinuses, and during suckling, milk is propelled from the lactiferous sinuses to the nipples by smooth muscle contraction. Now, the smooth muscle contraction is under the direction of oxytocin, which is produced by the posterior pituitary, and of course milk production is under the direction of prolactin, which is produced by the anterior pituitary. We'll talk more about the mammary glands and lactation in the next chapter on pregnancy and human development. Now, before you move on to that chapter, make sure you read the section on breast cancer, which is one of the most common and most deadly cancers in women, and this is located on pages 1042 and 1043 of your textbook. Now that we've learned about the female reproductive anatomy, we're going to go on to talk about the physiology of the ovarian and uterine cycles. Now, although we have these two different cycles, one that's going on in the ovary and one that's going on in the uterus, they are very much synchronized. Basically, each of them lasts approximately 28 days. And more importantly, what's going on in the ovary basically controls what's going on in the uterus. And this is because that the ovary secretes either estrogen or progesterone under the direction of the anterior pituitary hormones FSH and LH. So once you have the ovarian cycle down, it will be much easier to learn the uterine cycle. So before we go on to talk about these two cycles, we're going to discuss the myriad of hormones that regulates the female reproductive cycles. Now the first of these is GnRH, which stands for gonadotropin releasing hormone. Just like in males, GnRH is made in the hypothalamus, and it basically travels from the hypothalamus to the anterior pituitary, where it stimulates the production of both FSH and LH. So FSH is produced by the anterior pituitary, and it travels to the gonads, specifically the ovaries, where it's going to stimulate production of estrogen by our follicular cells. Now, estrogen is probably a hormone that you're very familiar with, but in truth it consists of greater than 6 different hormones, including beta-estradiol, estrone, and estriol. So estrogens collectively promote the development and maintenance of the female reproductive structures as well as the female secondary sex characteristics. And these includes things like increased fatty deposition in the hips, the buttocks, the thighs, and also the breasts. Increased anabolism. One of the things that estrogen does is helps females to conserve bone mass. And so during adolescence and after puberty, it helps us to actually build bone and conserve it. And then after menopause, when estrogen goes away, we actually have faster than normal bone breakdown. So basically, estrogen has a protective function against osteoclasts. The other thing that estrogen does is help us to lower our bad cholesterol and keep our good cholesterol at moderate levels. And so estrogen has a lot of benefits besides just basically promoting breasts and hips and things like that. The other thing you should remember about estrogen is that it's produced by the follicular cells under the stimulation of FSH and LH. and at moderate to low levels, estrogen is actually going to have a negative feedback on the anterior pituitary and the hypothalamus. So during these circumstances, if I inject you with a certain amount of estrogen, it will actually shut down your FSH and LH concentrations. And this is one of the reasons why we can use both estrogen and progesterone as a type of hormonal birth control. Another hormone that's important in the female reproductive tract is LH. LH is the other one of our gonadotropins produced by the anterior pituitary under the direction of GnRH from the hypothalamus. And LH helps to stimulate estrogen production, but more importantly, high levels of LH actually stimulate the process of ovulation. That is, when an egg ruptures from an ovary and enters the fallopian tube. The next hormone is inhibin. Inhibin basically inhibits secretions of FSH and LH at the end of the uterine cycle, and so it basically regulates the timing of the female reproductive cycle. The next hormone is another one you've probably heard about before, and it's called progesterone. Think about what that word means. Pro means for, and gesterone pertains to gestation. That is the process of basically raising and supporting a developing fetus inside the female uterus. And so basically this means go birth. And so progesterone basically helps to maintain the endometrium of the female uterus so that it can basically receive a fertilized egg, that egg can implant, and then it can form a placental connection. And so initially, progesterone is actually secreted by a layer of cells called the corpus luteum. And the corpus luteum is basically derived from a previously ovulated oocyte. A follicle ovulates, sending the oocyte out into the fallopian tube, and the remaining cells remain behind to become the corpus luteum, which now secretes very progesterone-rich fluids. Now, during the latter stages of pregnancy, progesterone secretion will eventually be taken over by the placenta. But until then, the corpus luteum will be very, very important in helping to maintain adequate levels of progesterone to keep the uterine lining nice and thick. So, now that we know about the various functions of all the different hormones that regulate the female reproductive tract, we're going to focus specifically on the ovarian cycle. As the name implies, this has to do with what's going on inside the ovaries. And the ovarian cycle is a 28-day cycle, and it's divided into 3 phases: a follicular phase, ovulation, and a luteal phase. So the first part of the ovarian cycle is called the follicular phase, and the follicular phase corresponds to days 1 through 14. That is, on average, it's about 14 days long. And we call it the follicular phase because it has something to do with the ovarian follicles. Remember, a follicle was simply an immature egg or oocyte that's surrounded by epithelial cells called follicular cells. And basically what happens during the follicular phase is that FSH and LH from the anterior pituitary stimulates the follicle to grow in size and become more developed. Now, as the follicle grows in size, it's not really the egg itself that's growing, but it's the follicular cells surrounding that egg that are growing and differentiating. And as those cells grow and differentiate, they're going to start to secrete large amounts of estrogen, which has feedback both on the hypothalamus and also on the anterior pituitary. The other thing that's going to happen is that one of the most mature follicles during each cycle will then begin to form a fluid-filled space called an antrum. And this follicle that has an antrum is called an antral follicle or a Graafian follicle. And this is going to be the follicle that ruptures during ovulation. Now, it's important to realize that we don't go from primordial follicle to vesicular or antral follicle all in 1 month. Basically, it takes several cycles for a follicle to go from primordial to vesicular. Typically, it's going to take somewhere between 11 months and 1 year. And so it's important to realize that each follicle in your ovary is affected by FSH and LH. And some of them are going to be developing just a little bit each month. And so the follicle that you ovulate, let's say this month, was probably actually recruited somewhere around 11 or 12 months ago under the direction of FSH and LH. Okay, the next phase of the ovarian cycle is called ovulation, and ovulation happens around day 14. And what happens is that the antral follicle that contained that large fluid-filled vesicle will basically move to the cortex or outside of the ovary, and it will rupture, releasing the oocyte into the abdominopelvic cavity. Now, ideally, that oocyte is going to pass into the infundibulum and into the fallopian tube. Now, what causes this ovulation? Well, basically we have a positive feedback between estrogen and FSH and LH levels. Earlier on I said that estrogen tends to have a negative feedback on the anterior pituitary, that is, it reduces the amount of GnRH secretion by the hypothalamus and FSH and LH from the anterior pituitary. But as the follicle grows and secretes more and more estrogen, the large levels of estrogen will actually flip-flop the thermostat of the hypothalamus and induce a positive feedback. So with large levels of estrogen, we stimulate more and more FSH and LH release, which stimulates more and more estrogen, which stimulates more and more FSH and LH release, and we have this surge in both FSH and LH. And the surge in LH, or luteinizing hormone, is what actually causes ovulation. Typically, ovulation happens within 7 to 9 hours after the peak in LH secretion. And finally, the last phase of the ovarian cycle is called the luteal phase. And this is from the time of ovulation to the end of the cycle. And so it's from days 14 to 28. So what happens is after ovulation, the ruptured follicle that's left behind will become a corpus luteum. Now, a corpus luteum is formed by the remaining follicular cells from that ruptured Graafian follicle, and as those cells begin to change, they will then begin to secrete more progesterone than estrogen. And this is important because progesterone is responsible for maintaining the endometrial lining of the uterus. And so this corpus luteum will begin to crank out progesterone for about the next 14 days. Now, if we don't have any fertilization taking place, after a while that corpus luteum will further disintegrate into something called a corpus albicans, and without the progesterone secreted by the corpus luteum, the uterus will begin to menstruate. That is, it's going to shed its endometrial lining. But we'll talk about that more when we get to the uterine cycle. So the big picture here is that after ovulation, the remaining follicular cells are called the corpus luteum, and the corpus luteum secretes progesterone, which is important to the maintenance of the endometrial lining of the uterus. So now that we've had this overview of the ovarian cycle, let's take another run through the hormonal axis that controls both the ovaries and eventually the uterus. So first we're going to start with the hypothalamus. Remember, the hypothalamus controls the gonads through secretion of GnRH, which stands for gonadotropin-releasing hormone. This GnRH travels to the anterior pituitary and stimulates the production of FSH, follicle-stimulating hormone, and LH, luteinizing hormone. Now, what do you think follicle-stimulating hormone does? Well, it stimulates the follicle. Remember that the follicle was basically the ring of cells surrounding an immature oocytes. So we called the whole thing the ovarian follicle. So under the direction of FSH and LH, that follicle is going to grow. And as it grows, the follicular cells will begin to crank out estrogens. Now, at low levels, estrogen actually has a negative feedback on the anterior pituitary and the hypothalamus. So as we get more estrogen, we tend to curtail our FSH and LH secretion. However, as the follicle gets larger and larger and larger, the more follicular cells we have will crank out more and more estrogen for a given amount of FSH and LH. And this is going to result in a large amount of estrogen returning to the anterior pituitary and to the hypothalamus. And this is going to basically cause a positive feedback mechanism. More estrogen from the ovary is going to result in more FSH and LH secretion, which is going to result in more estrogen from the ovary, which is going to result in more FSH and LH. So eventually we're going to get this large peak in both FSH and LH. And this surge in LH is particularly important for causing ovulation. The LH stimulates the most mature follicle to rupture, and the rupture of that follicle is going to send the ovulated secondary oocyte out into the abdominal pelvic cavity, where hopefully it's going to be scooped up by the infundibulum and the fallopian tube. Now, the cells that are left behind in the ovary are going to be called the corpus luteum. And remember, the corpus luteum is actually the remaining cells that were once part of that antral or Graafian follicle. Now, the corpus luteum is going to begin to alter its secretions. Prior to ovulation, the follicle was secreting primarily estrogen. Now, after ovulation, the corpus luteum is going to primarily produce progesterone. Now, progesterone and estrogen is both going to feed back on the anterior pituitary, again establishing a negative feedback. This is going to prevent it from releasing any further FSH or LH, which is going to stop ovarian development until the breakdown of that corpus luteum. Now, if we continue to have high levels of progesterone and estrogen, this can keep the ovary from developing new oocytes for several months. And this is basically what happens during pregnancy and also what happens when we take birth control pills. Birth control pills typically contain progesterone and estrogen, and basically they trick the body into thinking it's already pregnant. Remember, at intermediate levels, estrogen and progesterone actually have negative feedback on the anterior pituitary and hypothalamus. They prevent the development of new oocytes, and they also prevent implantation. So used properly, hormonal birth control can be very, very effective. So this slide just gives us a nice recap about what's going on during the ovarian cycle. Remember, the ovarian cycle consists of 3 phases: a follicular phase, ovulation, and a luteal phase. During the follicular phase, our follicles are basically growing under the stimulation of FSH and LH from the anterior pituitary. Now, around day 14, we will then proceed to ovulation. Ovulation occurs because we have high levels of LH, or luteinizing hormone, and this basically causes the rupture of the antral or Graafian follicle, and the egg or oocyte is going to move into the infundibulum, and the remaining follicular cells will now become the corpus luteum, which puts us into the luteal phase. Now, during the luteal phase, those remaining follicular cells, called the corpus luteum, will begin to secrete lots of progesterone and a little bit of estrogen. And the progesterone is going to be very important for maintaining the uterine lining, but eventually the progesterone levels are going to go down as that corpus luteum degenerates into corpus albicans. Now, this slide is an overview of the various hormone concentrations in the bloodstream throughout the 28-day ovarian cycle. Let's start at day 0. What's happening? Well, remember, day 0 to 14 was the follicular phase. And during the follicular phase, FSH and LH were stimulating the follicles to grow, and as the follicles grow, they're going to start to crank out a little bit more and a little bit more estrogen. And so around day 6, you can see the estrogen levels beginning to rise as the follicles get larger and more responsive to FSH and LH. Now, initially, these estrogens have negative feedback on FSH and LH, but as they begin to rise, the control actually flip-flops, and all of a sudden we have positive feedback. So as you can see, we have this peak in estrogen occurring, and just after it, we also have a peak in LH and, to a lesser extent, FSH. Now, this peak in LH secretion occurs right around days 14. And remember, LH was the cue that caused ovulation. That is, rupture of that follicle and movement of the oocyte into the abdominal pelvic cavity, where it's eventually scooped up by the fallopian tube. Soon after ovulation, you see FSH and LH levels go down, and very quickly after that, you see progesterone levels rise. Remember that progesterone is secreted by the corpus luteum, which is basically that sac of cells that was part of the Graafian or antral follicle, but now that the egg has been ovulated, it's going to switch what it's secreting. Before ovulation, it was secreting primarily estrogen, and now after ovulation, it's secreting primarily progesterone. And progesterone is going to be important for the maintenance of the uterine lining. Progesterone levels are eventually going to go down around day 28 if we don't have fertilization. So now that we've learned the ovarian cycle, it should be much easier to learn the uterine cycle. Because remember, everything that's going on in the uterus is actually controlled by what's going on in the ovaries. And the uterine cycle is divided into 4 phases: a menstrual phase, a proliferative phase, ovulation, and a secretory phase. And just like the ovarian cycle, the uterine cycle is typically 28 days in length. The first phase of the uterine cycle is called the menstrual phase, and this corresponds to days 1 through 5 of the 28-day cycle. And within the ovarian phase, it corresponds to the earlier follicular period. And basically, menstruation is the shedding of the uterine lining, more specifically the stratum functionalis. And this happens because we have declining levels of ovarian hormones, especially progesterone. So this just shows a diagram about what's going on both in the uterus and also in the ovaries. Now, in days 1 through 5 of the reproductive cycle, the amount of progesterone and estrogen that we've secreted has gone down because the corpus luteum has broken down. And so what's happening is we begin to have a sloughing off of the stratum functionalis of the uterus, and we go from uterus that's maybe 14 or 15 millimeters thick to something that's only a few millimeters thick. The next phase of the uterine cycle is called the proliferative phase. Proliferative means to build up, and during the proliferative phase, the uterine lining is going to build in thickness. We also call this the preovulatory phase because it occurs before ovulation. The proliferative phase corresponds to the late follicular phase of the ovarian cycle. And unlike other phases, it can be very variable, somewhere between 6 and 13 days. So basically what happens during the proliferative phase is that under the influence of estrogen, the endometrium will rebuild itself. That is, a new stratum functionalis will be generated from our stratum basalis. Towards the end of the proliferative phase, the cervical mucus will begin to break down, allowing passage of sperm from the vagina into the uterus. So once again, here's a picture of what's going on in the proliferative phase. You can see that the uterine lining is starting to build up in thickness under the directions of estrogens. Remember, the estrogens are being secreted by the developing follicles under the direction of FSH and LH. Now remember that ovulation is going to occur around day 14 in response to peak levels in LH, or luteinizing hormone. And this is going to cause the rupture of the most dominant follicle, and basically the remaining follicular cells are going to be converted into a corpus luteum. Which brings us to our next phase, the secretory phase. So the secretory phase is the time between ovulation and the beginning of the next menstruation. So it typically lasts around 14 days. And so what happens is basically under the direction of progesterone, which is coming from the corpus luteum, the stratum functionalis is going to continue to thicken up to 1 to 2 centimeters, and it's also going to grow endometrial glands, which will secrete nutrients such as glycogen into the uterine cavity. Now, soon after ovulation, the cervical mucus, which tended to break down towards ovulation, will once again become more sticky and solidify into a cervical plug. This cervical plug will isolate the uterus from the vagina. Okay, so here's a picture of the secretory phase, and we call it the secretory phase because under the direction of progesterone from the corpus luteum, the endometrium will build up to its thickest thickness, and it will also begin to secrete things like glycogen from its secretory glands. And glycogen will be important for possibly nurturing a fertilized egg until it has a chance to implant. And it's also important for maintaining the pH of both the uterus and the vagina. Okay, just like we had a summary slide of the ovarian cycle, here's a nice summary slide of the uterine cycle. Remember that days 1 through 5 are called the menstrual phase. Menstrual phase happens because we have no progesterone. If we don't have progesterone, the uterine lining is going to break down. The next phase is called proliferative phase, and under the proliferative phase, the endometrial lining is going to build back up again. And that's going to happen because our developing follicles are going to start secreting estrogen, and estrogen is important for that buildup in the endometrial lining. Now around day 14, what happens? That's right, ovulation. Ovulation happens because we have peak levels of luteinizing hormone. After ovulation, our corpus luteum is going to hang around and it's going to begin to secrete a lot of progesterone. Now, progesterone puts us into the secretory phase, and here our endometrial lining is at its thickest, and we also have secretions of the endometrial glands, which are secreting glycogen. Now, you might be asking, what's going to happen at the end of this 28-day period? Well, what happens will depend on whether or not we've had fertilization or not. If fertilization has occurred around the time of ovulation, what will happen is the corpus luteum will be maintained by a secretion of human chorionic gonadotropin, which is produced by the dividing embryo. HCG travels through the bloodstream and reaches the corpus luteum, and it tells it not to break down. If the corpus luteum doesn't break down, it will continue to secrete progesterone, which is necessary for maintaining the uterine lining. And this is really important because if you're pregnant, you want to make sure that uterine lining is nice and maintained. In the first couple months of pregnancy, that is the job of the corpus luteum. Now let's look at the opposite. Let's say that we had ovulation, but we didn't have fertilization. Now, if no fertilization takes place, the corpus luteum is going to break down by day 28. And as it breaks down, its secretion of progesterone and estrogen is going to cease. And without this progesterone and estrogen, the uterine lining is then going to break down and undergo the process of menstruation once again. Now, just like in males, females aren't born with functional ovaries and estrogen secretion. They have to go through the process of puberty. So during childhood, the ovaries in fact are secreting micro amounts of estrogens, and during childhood the hypothalamus is very sensitive to these estrogens, and there's a very tight negative feedback loop that prevents the hypothalamus and anterior pituitary from secreting much FSH or LH. But as the child gets older, their hypothalamus will become less sensitive to the effects of estrogen. And so it takes larger amounts of estrogen to elicit this negative feedback onto FSH and LH. Now eventually the hypothalamus will basically set itself at its adult threshold for estrogen, and we're going to set the regular cycle between FSH, LH, and also estrogens. So eventually, if everything's working correctly, we're basically going to reach the adult hormonal cycle where GnRH is produced by the hypothalamus. That elicits production of FSH and LH from the anterior pituitary, and the FSH stimulates estrogen secretion by the developing follicles, and after ovulation, those follicles will then become corpus lutea and secrete progesterone. Now, these aren't the only hormones that are important for setting the timing of puberty. There's another hormone called leptin, which is produced by adipose tissue, which is very important for setting the timing of puberty. In particular, people that don't have enough adipose tissue may not go through puberty as early as people that have adequate amounts of adipose tissue. And we think this is basically a very helpful regulatory mechanism that helps the body determine whether it has adequate amounts of caloric reserves in terms of fat in order to sustain a pregnancy. So women that are very low in body fat, or let's say are very highly trained athletes, will often go through a process of amenorrhea. Basically, even if they were having their period, they stop having their period because they don't have adequate amounts of body fat. So we already talked about some of the functions of estrogens in the body. Obviously, we said they're important for the growth of the endometrial lining, and they're also important for setting the negative feedback between estrogen, FSH, and LH. They also have effects elsewhere in the body. They help with the development of these secondary sex characteristics, such as growth of the breasts, increased deposition of fat in the hips and buttocks and thighs, and they also help with the widening and lightening of the pelvis, which adapts us for childbirth. They also support a rapid but very short-lived growth spurt around the time of puberty. Now, in addition to promoting secondary sex characteristics, estrogen also has some very important metabolic effects. For one thing, it helps us to maintain low LDL levels and high HDL levels. The other thing it helps us do is maintain adequate calcium stores in the bone. Estrogen actually inhibits osteoclasts. Remember, osteoclasts were basically the cells that break down bone, and they take calcium out of bone and put it in the bloodstream. And so estrogen has a protective function. It helps to reduce the activity of these osteoclasts and helps to keep calcium in the bones. Now, just like in males, the process of puberty in females happens between the ages of about 8 and 13. And so, the left-hand side of the screen, you can see a girl that's maybe age 8, and you can see that she looks very androgynous. She doesn't really have any hips, breast development isn't there, there's no hair. But what happens over the next few years is that rising levels of estrogen stimulate the deposition of fat in the buttocks, the thighs, the breasts. The other thing that we get is the hips become wider, and also we get pubic hair and axillary hair forming in the armpits and groin. And so usually around the age of 14 or 15 or so, the process of puberty is complete or nearing completion. And it's important to realize that this is going to signal the closure of the epiphyseal plates, which is basically going to stop any type of growth in height. We're now going to move on and talk about the female sexual response. Now, the female sexual response is much more difficult to study than the male sexual response, and that's principally because a lot of the things that are going on are inside the female and cannot be observed directly from just looking at what's going on the outside like we can in males. And so, just like in males, the female sexual response is initiated by tactile stimulus, by psychological stimulus, by even smells. And the erogenous areas here are the clitoris. The clitoris contains 9 times the number of nerve endings that are found in the glans penis, which was very sensitive in itself. And when a female becomes sexually aroused, there's going to be an increase in mucus secretion. The vestibule underlying the labia is going to enlarge, because remember that contains lots of erectile tissue. And also there's going to be more glandular secretions as well. Now, when an orgasm occurs, there's going to be a sudden increase and decrease in muscle tension and the same increase in pulse rate and blood pressure that happens in males. Because remember, arousal itself may be a parasympathetic event, but the act of orgasm is usually going to be a sympathetic event. Now, the stages of sexual response in females is thought to be very similar to what it is in males. And these were described by Masters and Johnson. And so they describe these 4 different phases: excitement, plateau, orgasm, and resolution. Excitement in females is similar to what it is in males. That psychological or tactile stimuli is resulting in engorgement of our erectile tissues. Here we're talking about the bulb of the vestibule underlying the labia, and also the clitoris. Now, eventually we're going to reach a plateau phase. During the plateau phase, we're going to have increased secretions of the vagina and the cervix, increased lubrication of the external genitalia. Now, during orgasm, females will have this rhythmic muscular contraction within their abdominal pelvic cavity. In fact, Masters and Johnson thought that the uterus itself would flip-flop back and forth basically on the stem of the vagina. As we're going to see in a second, this may not be the case. And then finally, during resolution, the uterus will go from this very large engorged state to shrinking back down and becoming quite a bit smaller, and then flopping over anteriorly, sitting on the urinary bladder. So these are the stages of sexual response as envisioned by Masters and Johnson. Now, it's important to realize that Masters and Johnson did their work in the 1960s, and a lot of what they did to figure out what was going on inside the female body was just asking the person having the orgasm what's going on, maybe palpating the outside of the abdominal cavity while that person was having an orgasm. In any case, I'm going to show you another study that may conflict a little bit with the information provided by Masters and Johnson. Now, more recently, a group of British researchers have been able to use MRI technology to look and see what's going on in the female body during sexual arousal. And so here you can see 3 MRI mid-sagittal sections through the female body. The leftmost section was taken during resting, that is prior to sexual arousal. I've gone ahead and labeled things so you can get an idea where the spine is, where the uterus is, where the vagina is, and where the bladder is. Now take a look at the middle picture. This was taken of a female after adequate stimulation, and here she's in the plateau phase of sexual arousal. How do things look different? Well, the first thing you probably look at and say, well, the bladder seems to be quite a bit larger. Maybe she just really has to pee. But what's happened here is the bladder doesn't actually contain significant amounts of urine at this point. The researchers actually think the bladder appears larger because the vagina has grown longer in the process of stimulation, and it's also forced the uterus upwards. Now, it's important to point out that they found that this happens regardless of whether or not a penis enters the vagina. That is, if the woman masturbates, the vagina will still grow in length. And finally, let's look at the last photo. You can see that the urinary bladder is quite large now. Again, it's been stretched out because of that stretching of the vagina. The other thing that you're going to notice is that the size of the uterus really hasn't changed. And that is in counter to what Masters and Johnson thought. They thought the uterus was going to engorge with blood, get a lot larger, but the MRI images don't tend to bear this out. Now, if you want to see the whole paper, it's available for download for free. Just click on the link below. So the last slide just showed stages of sexual arousal in the female through MRI sections. Now, this page actually shows basically sexual intercourse between a man and a female in the missionary position. Now, everything that's shown in the left-hand figure is also shown in the right-hand figure, but basically it's labeled with a special key so you can see just exactly what things are. The penis is that long sort of boomerang-looking thing, and that was unusual. Prior to this study, we didn't know that the penis actually makes a boomerang inside the vagina. You can see the testes, you can see the uterus, it's laying on its side, it's not flip-flopping up and down, and of course you can see the urinary bladder of both the male and the female. And so this was the first study ever where we were actually able to see sexual intercourse in an MRI. And it was possible for a few different reasons. One was because now we have faster MRI machines. The other thing is we have willing participants. The particular couple that you see here was actually a group of, I think, street acrobats, and so they were used to performing in public and under pressure. And finally, the last reason why studies like these weren't previously possible is that men tend not to be able to hold an erection for long enough to take the MRI pictures. And so it was only with the benefit of Viagra that was used in this study that the individuals were able to get these pictures taken of the different sexual intercourse positions. And that's because even though they have faster than normal MRIs now, I think they still have to have the people standing still for a couple minutes at a time while they take the MRI image. Anyways, if you want to see more of these pictures or see more what sexual intercourse looks like in an MRI, go back to the previous slide and click on the link at the bottom of the page. Okay, so now that we talked about sex and everything fun, now let's talk about the things that aren't fun. That is the sexually transmitted infections, STIs, previously known as STDs. Now, U.S. has very, very high rates of infection. Now, most of you know that latex condoms are a fairly effective means of birth control and tend to be very effective, the most effective means of preventing sexually transmitted infections. The problem with condoms is that people don't use them. Now, not only can sexually transmitted infections lead to things like herpes, which you don't want to get, they can also lead to life-threatening conditions such as HIV, and they can also lead to reproductive disorders that eventually result in sterility. And this tends to be the area that few people are familiar with. In fact, sexually transmitted infections are one of the leading causes of infertility in women. So our first sexually transmitted infection is gonorrhea. Gonorrhea is commonly called the clap, and it's basically caused by a bacterial infection of the mucosa of the reproductive tracts and urinary tracts. And it can be spread by contact with genital, anal, or pharyngeal mucosae. As you can see it right, this person actually has some gonorrhea within his lips and also in his gums. Now in males, gonorrhea typically manifests itself as urethritis, that is inflammation of the urethra, painful urination, and as you can see it right, discharge of pus from the penis. Now in females, many will be asymptomatic, that is 20% will have no symptoms. Some will have abdominal discomfort, some vaginal discharge, maybe some abnormal uterine bleeding, but the big important part is that even in the people that have no symptoms, the inflammation that results can cause pelvic inflammatory disease, which in females can result in sterility. Now, gonorrhea is a bacteria, and so it does respond to antibiotics, but more recently we're starting to see some antibiotic-resistant strains that are very resistant to common antibiotics. Okay, our next STI is syphilis. Syphilis is also a bacterial infection which is transmitted sexually, or it can also be contracted congenitally. That is, if we have a mother that has syphilis, if she's giving birth to an offspring, that child can come in contact with the syphilis bacteria through the process of birthing, and this can actually lead to infection of the newborn and even death. Initially, there's something called the primary infectious period. During the primary period, the people tend to be asymptomatic for at least the first 2 to 3 weeks. After that, they might get a few spots which are called canker. These are sort of painless red spots that appear at the site of the infection, that is on the penis, the scrotum, around the labia, and then a couple weeks later they're going to disappear. Now, if it's not treated, that primary syphilis will eventually turn into secondary syphilis. Basically, 3 to 12 weeks post-infection, we're going to get a skin rash, we're going to get a fever, and lots of joint pain. So it's going to be a little bit more severe this time. Now, secondary syphilis will eventually go away. We'll get this latent period, and latent means hidden. Basically, there's no sign of infection, but we can still transmit the disease. We still test positive for it in our blood serum. Now, if we're not treating this person with antibiotics, they can proceed from the latent phase to a tertiary phase and eventually to a neurologic phase. So during these latter phases, we get these formation of lesions called gumas, which can form within the liver, within the scrotum and testes, and even within the brain. And these gumas are basically non-cancerous lesions similar to granulomas that can occur in various organs of the body. Now, if they occur in the brain, they can obviously lead to destruction of nervous tissue, and a lot of people that have syphilis and are untreated for it can eventually become mentally insane because of the effects of this bacteria on the brain. At the right-hand side, you can see some of the effects of syphilis on the 4 to 5-year-old who probably contracted syphilis congenitally. Now, fortunately, we have penicillin that works very good to destroy the syphilis bacteria, but previous to the development of penicillin, it was common for people to get and even die from syphilis, and it's still very, very common in third world countries. Another type of sexually transmitted infection is chlamydia. It's the most common bacterial STI in the United States, and it's responsible for around 25 to 50% of all diagnosed cases of PID, or pelvic inflammatory disease. Now, PID is very important because it can lead to inflammation and infertility, particularly in females. Now, the symptoms of chlamydia include urethritis, that is inflammation of the urethra, discharge of both the penis or the vagina, abdominal or rectal pain, testicular pain, painful intercourse, dysmenorrhea, which is basically irregular menses. It can also cause arthritis and urinary tract infections, and again, this inflammation can lead to sterility, which is very, very important. Now, because chlamydia is a bacterial infection, it does respond quite well to antibiotics, particularly tetracycline. Now, the big take-home message for chlamydia is this: it causes inflammation, but oftentimes this inflammation can be asymptomatic. And it's important because even asymptomatic inflammation can lead to permanent damage to the fallopian tubes. Remember, we said the fallopian tubes were basically passageways for ovulated oocytes to pass from the ovary into the uterus. Now, it's important to realize that the diameter of the fallopian tube in some places is the width of a human hair, and that any type of inflammation that occurs there can drastically reduce and close off the fallopian tube, preventing any ovulated oocytes from getting to the uterus. If the oocytes can't get to the uterus and the sperm can't get to the tube, then our chances of conception are virtually nil. And so it's important that you are evaluated for STIs such as chlamydia, and that if you have them, they're treated very, very promptly so that they don't result in this chronic inflammation which can render you sterile. Now, our next sexually transmitted disease is trichomoniasis, or trich, and it's the most common curable sexually transmitted infection in the United States. And it's caused not by bacteria, but actually by a protozoan. And a protozoan is just basically a single-celled eukaryotic organism. And the protozoan here is called Trichomonas vaginalis. And it's spread from person to person through sexual contact. In some people, it leads to urethritis, particularly in men, or it can lead to a yellow-green vaginal discharge in women. However, in the majority of the cases, you're asymptomatic. You don't even realize you're infected with this organism. So why do we care? Well, trichomoniasis in itself isn't that bad, but the lesions that are created may make you more susceptible to other types of sexually transmitted infections. So that's why it's a good reason to get yourself screened, and if you have the infection, they can treat it very easily and very cheaply with a single dose of antibiotic. Okay, now we're going to move on to the viral infections, and the first of these is genital warts. Genital warts is caused by HPV, which stands for human papillomavirus, and this is the second most common sexually transmitted disease in the United States. If you have HPV and genital warts, it can put females at increased risk for cancers, particularly cervical cancer. Approximately 80% of the cervical cancers are linked to HPV infection. Fortunately, pharmaceutical manufacturers have recently come out with a vaccine that can protect females against most types of the HPV virus, at least those that tend to cause cervical cancer. And so the FDA and CDC have shown that this vaccine is very, very effective and also very safe. Unfortunately, it's quite controversial because of the age at which it has to be administered. In order to be effective, the vaccine has to be administered to girls between the ages of 9 and 12. And the problem is, this is well before any parent wants to think of their daughter as being sexually active. And so many of the more conservative parents are very, very resistant about giving their child this vaccine. They go on the internet, they search for things that might be bad about it, and of course you can find any crackpot website that says, well, this HPV vaccine could be linked to sterility, this, that, or the other thing. But again, the CDC, the FDA have shown that this vaccine is very, very safe and it's very effective. And it's the one thing they can do for your child to help ensure that they're never going to come down with this deadly form of cancer called cervical cancer. So if you have children that are about that age, talk to your pediatrician about when they should get the HPV shot. Now, another type of viral infection that affects the reproductive systems of both males and females is genital herpes. And genital herpes is caused by a herpes simplex 2 virus. It's similar to the virus that causes cold sores around the mouth. It is characterized by these flare-ups of red bumps that can occur on the buttocks, on the scrotum, on the penis, and also on the vulva, and then they go away. So we have these flare-ups, and we also have latent periods where you can't tell that somebody has herpes. And because herpes is a viral infection, there's no real cure for it. We can use antiviral drugs like acyclovir that will basically reduce the frequency of flare-ups, but we're probably not going to get rid of herpes from the body. Okay, we should also talk a little bit about birth control measures. You're probably very familiar with the different types of birth control, and these include things like oral contraceptives, barrier devices, and also the intrauterine devices. Now, oral contraceptives and also implantable contraceptives basically work by inhibiting the release of FSH and LH from the anterior pituitary. Basically, oral contraceptives contain a mixture of estrogen and or progesterone that has a negative feedback on the hypothalamus. This causes the hypothalamus to stop release of GnRH and stops the release of FSH and LH from the anterior pituitary. With no FSH and LH, we don't have growth of new follicles, and we also don't have ovulation. Now, oral contraceptives can be quite effective if used properly. That is, over 95% effective. But a lot of times people will tend to forget a pill every now and then, and of course the efficacy goes down. Other types of hormonal birth control include implantable devices. For example, Norplant was a common implantable device. And these are inserted underneath the skin, and they release microdoses of estrogen over time, which again inhibits the hypothalamus pituitary axis and prevents oocytes from being ovulated from the ovary. And this tends to work a little bit better because you don't have to remember, that I need to take a pill every day. And of course there are the barrier methods. These are things like condoms and also diaphragms. Condoms very low tech. It prevents the sperm, when ejaculated, from getting into the vagina and hopefully up the fallopian tube. Unfortunately, condoms do rip sometimes, and so they have a little bit lower success rate. The one good thing about condoms is they are the only type of birth control measure that can reduce your chances of getting STDs. Okay, the last type of birth control measure we should mention are the intrauterine devices. And these are, again, very low tech. They are devices that are inserted by your gynecologist into the uterus, and they may consist of plastic impregnated with hormones, or they may just consist of metal. And these are among the oldest types of birth control measures. We now know that there were intrauterine devices that were manufactured back in medieval times. And basically the IUD sets up sort of a low-level amount of inflammation in the uterus. And this low-level inflammation basically prevents fertilized egg from implanting in the uterus. Okay, before we stop this lecture, we need to talk about the process of menopause. And menopause is basically the process whereby the female reproductive cycle stops when a female reaches, let's say, her 40s or 50s. We say that menopause has occurred when menstruation has not occurred for an entire year. And it's important to point out that there's no equivalent to menopause in males. Males basically will continue to produce testosterone well into their 80s and 90s, and they'll even produce viable sperm at that point. And so even though sperm levels may go down, sperm quality may go down, testosterone levels go down, we don't see this abrupt decline like we do in females. So menopause is caused by an abrupt decline in estrogen levels as the female reproductive cycle ceases. And this can lead to the atrophy of the reproductive organs, including the breasts. It can lead to irritability and depression in some people. It also results commonly in hot flashes and mood swings. It can result in a thinning of the skin, hair loss, and also bone loss. Because one of the things that estrogen did was inhibit osteoclasts. So all of a sudden, when there's no more estrogen, the osteoclasts just go mad and begin to break down bone, which can very quickly result in osteoporosis. The other bad thing that happens is that the levels of LDL in the bloodstream go up and the levels of HDL go down. So the signs and symptoms of menopause can vary widely among individuals. Some people I know have had a very easy time with menopause, whereas others have basically had a very difficult time with it. And so previously, if people were having a very difficult time with menopause, we would do something called hormone replacement therapy, whereas basically the doctor would prescribe them a pill that would contain estrogen in it. And one of the most common brand names that was prescribed was something called Premarin. And Premarin contained conjugated estrogens that would help to replace the estrogens that were no longer produced by the female body. Now you might be asking, why does he have a picture of a horse over there? Well, the word Premarin comes from pregnant mare urine. Basically, we extracted these conjugated estrogens from pregnant horses called mares. And because the mares were pregnant, they were excreting massive amounts of estrogen through their urine. So we collect their urine, we sterilize it, and we basically package it into pills like Premarin. So if you were taking hormone replacement therapy, it's possible you were actually eating horse urine metabolites. Now, if you ever talk to people that have used hormone replacement therapy as a treatment for menopause, they will swear by it. They will say that it helps to bring their memory back, it gets rid of the hot flashes, it helps their skin to be more supple and younger looking. But as it turns out, doctors now think that long-term treatment of menopause using HRT is probably not a good idea. That's because we now know that it leads to an increased risk of heart disease, breast cancer, stroke, and dementia. Now, short-term use of hormone replacement therapies, let's say for 6 months or maybe even a year, probably doesn't have a very long-term effect on survivorship. But there was a point in which people were basically putting their patients on HRT for 10 years, 15 years, or even 20 years. And if taken for a long enough period of time, this really does result in some very real risks to a person's health. And so most doctors nowadays will only prescribe hormone replacement therapy in the most severe cases. Okay, you've now reached the end of the lecture on the female reproductive system. Now, we didn't get a chance to cover all the topics in today's lecture, so please be sure to read about breast cancer, including treatments and diagnosis, and also be sure to read the end part of the chapter that deals with developmental aspects of the reproductive system. So after reading that section, you should be able to describe the genetic basis for sex determination. You should be able to tell me which structures in the male reproductive tract are homologous to which structures in the female reproductive tract, and you should also be familiar with the different disorders that can happen as a result of non-disjunction during meiosis.